Good afternoon, everyone. I hope you've enjoyed your lunch. It was really tasty. My name is Andy Wilson, and I'm with Abbott Fund and responsible for our work in Tanzania. As a long-term sponsor of the Women in Global Development Forum, we're really delighted and proud to have someone as influential as Dr. Vanessa Kerry, co-founder of Seed Global Health. Before I get started, I will say a few words about when I first met Vanessa. She travels. Vanessa travels around as an advocate for global health. I met her first in Boston and then in Tanzania. We actually did some site visits together and spent some time together. Then we met in Washington, D.C. We now are meeting in Chicago. And I think she's been to probably 100 other places in the last few years since we met. She's a tireless advocate for training doctors and nurses. The WHO indicates there's about a deficit of about 7.2 million physicians, nurses, and midwives in the world. These are mostly caused by inefficiencies and underfunding of healthcare systems infrastructure, but also training in doctors and nurses. The impact of this lack of support and lack of physicians and medical infrastructure is grave, and it's disproportionately impacted in developing countries. If you think of the HIV and AIDS pandemic, think of the Zika virus, and also Ebola. What's being done to address all of these things? Well, multiple organizations work to have an impact. Abbott Fund is among those. In Tanzania, we work with the government to build health systems infrastructure, train physicians in emergency medicine and laboratory technicians. We also work there with Dr. Kerry and Seed Global Health. The work there, we've worked with Seed to train physicians and nurses in cardiology, anesthesia, and critical care, and they've also helped to improve protocols, which has had a significantly good impact on the lives of multiple patients. We're pleased to have Dr. Kerry here with us today. I think most of you all probably saw her bio in your handout. She is a physician at the Mass General Hospital. She leads educational activities at the hospital's Center for Global Health. She spearheads a program in global public policy and social change at Harvard's Medical School, Department of Global Health and Social Medicine. She is an active mom and just a great person. Her work's been featured in the New England Journal of Medicine and the New York Times. Ladies and gentlemen, please join me in welcoming Dr. Vanessa Kerry.
Active is absolutely true. My children are currently at the aquarium here in Chicago, and if I stutter over words, it's because my 4-year-old spent the entire night kicking me in bed. So it's a family trip to Chicago, which is actually really, really fun. But it's a pleasure to be here, and I really want to thank you, Andy, for your introduction, but also just the partnership with Abbott. I mean, it's been a really incredible experience for us to have the opportunity to work in Tanzania with you and to begin to try to make a dent in this huge problem, which I think you've already been leading with at Abbott in terms of the work you're doing, and we are just privileged to be able to try to help grow. So thank you. And I want to thank the Chicago Council for having me. This is a really neat thing. I don't get to do a lot of things like this in terms of sitting down and being able to learn or listen or engage in a conversation. I feel like, to Andy's point, I am always traveling. So it's just really wonderful to be able to join you and to have an opportunity to have a discussion with you today. I'm going to attempt to try to outline a really big problem in about 30 minutes, and more importantly, to outline what we hope is a really important and strong and viable solution for how to fix this problem. I hope you all saw you have some really interesting data on the back of your program. I was actually really impressed to see this because It does, I think, pictorially outline exactly what we are talking about, and that is that there is a fundamental critical shortage of health professionals, all healthcare workers, but I'm going to talk specifically about health professionals around the world. And the World Health Organization had said back in 2006 that there was a critical shortage of 2.4 million doctors, nurses, and midwives. But 2 years ago, they updated that to be 7.2 million doctors, nurses, and midwives. And the estimation is that by the year 2035, that number is going to rise to 18 million. So this is not a problem that is going away. It's a problem that's getting worse. And I think what's interesting is that not only is there a critical shortage of doctors, nurses, and midwives, but there's not the right distribution of them in many ways as well. And if you look at because in the US, we technically don't have a shortage, but if you walk a few blocks south, you might see there is a critical shortage. And so these are all the things that we need to be thinking about. It's just not just how do we create numbers, but how do we put them in the right place? So the World Health Organization did outline this critical shortage. And I think what's notable, though, is that there are regional variations to this distribution. Again, the US may not have a critical shortage. Europe actually has an excess of doctors per population. But in sub-Saharan Africa, where we work, 47 out of 56 countries have critical shortages, which means that over 75% of countries on that continent don't have nearly the kind of health professionals they need. This distribution is geographic, and if you look at that lower picture on your thing, you can see it's pretty concentrated, and it's pretty concentrated in sub-Saharan Africa. And I think that that's a big reason that we chose to start to work there. There's 25% of the global burden of disease lies just in sub-Saharan Africa, but it has only 3% of the world's healthcare workforce with which to try to rectify that. And perhaps even more startling, it has only 1% of the world's healthcare expenditure to try to solve that. So recognizing that, the question is why? There's a lot of reasons that has started to happen. One has been structural readjustment programs that were put in place in the 1980s. So as we sort of hit the 1980s and there was coming out of the 70s recession and everything that happened, there's a real movement by the World Bank and the IMF and others to try to decrease social spending in these countries. And that meant spending didn't go into health and spending didn't go into education. And so as a result, suddenly, there was no money to train people, and there's no money to sort of practice in health. And so a lot of people started to leave in the phenomenon that many of you are familiar with called brain drain. So people started to look for opportunities in other countries where they could practice what they trained in, where they could be paid, where their children could go to good schools, where they didn't have to be caught in the middle of conflict. And what that did was it led to, one, people leaving, but two, nobody coming through the pipeline to fill the people who left. So now there's these huge shortages of these health professionals in these countries. There's internal brain drain as well. Not only were people fleeing countries, but people were also being hired maybe into NGOs and into organizations within countries. And so even if they're staying in the country, they're not actually working in the public sector anymore. A colleague of ours at Seed Global Health wrote a paper in which he studied the rates of emigration of people out of these countries and found that while the Philippines is the #1 exporter of health professionals, it's actually a commodity for them. They have enough health professionals. They are training health professionals to leave because they rely on those remittances to come home and help fund their economy. But of the top 20 countries with the highest rates of emigration of healthcare workers, 9 of them come from sub-Saharan Africa. So again, it's contributing to that map that you're seeing on there. But there's another problem that's been evolving, not just the lack of sort of enough of these doctors, health nurses, and midwives, but there's a leadership gap in these countries that's been resulting. And so that as we're thinking about how are we going to solve these problems, think about these problems, write about these problems, and create conversation about the problems, the people who are most engaged in talking about these things aren't actually living in these countries and living it firsthand. So if you type in the word HIV into PubMed, which is a medical database, and you look at the top 3, a friend of mine, a colleague of ours did this in 2007, typed in the word HIV and looked at where the top articles were coming from, the first 300, and he mapped the home institution of the first author, which is traditionally the person who's asking the question, doing the research, and writing about HIV in this case. And he mapped where that first author was from. 37% were from North America, 21% were from Europe, and only 8% were from sub-Saharan Africa, but that's where 75% of the global burden of HIV is. So you have a huge gap. The people who are writing about this, thinking about it, are actually not the people who are actually living it and know what it means for their community to be affected, knows what it means, for to have their brother die of the disease. And that's a gap that we need to think about closing. There's also a specialty gap. I'm sure you've all read about this and heard about this, but there's a rise of non-communicable disease happening around the world. So that now cardiovascular death is the leading cause of death worldwide and is about to be the leading cause of death actually in Africa, no longer HIV. Chronic obstructive pulmonary disease is the 5th leading cause of death. Malignancy is the 3rd leading cause of death globally. And so we're making a shift from infectious disease towards these non-communicable diseases. These countries don't have any experience dealing with these non-communicable diseases. It's an expertise that is entirely lacking. A country like South Sudan, which is still mired in conflict, has no specialists in the country. 500 doctors, not one is a specialist. In Africa, a specialist means a pediatrician, an obstetrician, a general surgeon, an internal medicine doctor. They've all graduated medical school and they're off to be doctors, which is not really sufficient. So there's a huge gap there that we need to be thinking about. Zika virus is on everybody's minds right now. The bad news is no matter what healthcare system you are in, Zika is going to affect you. So we are not going to be immune in the United States from Zika virus in any way, shape, or form. But what we are going to be able to do is to much better mitigate the effects of Zika virus, much better prevent its transmission. And we're much likely to have a socioeconomic hit from Zika virus than other countries around the world. It is a disease that is going to prey and hurt the poor. And that is something that is certainly going to be an issue in the countries in South America and in sub-Saharan Africa. And what becomes critically important, though, is that we are thinking about building kind of the expertise to cope with it, but also to be thinking about it again. Because the solutions for Brazil or for South America need to come from Brazil and South America, not to say that we don't have a responsibility to help, but understanding how to implement programs that are going to stop Zika virus, you need to make sure that they're going to be adopted by those that are going to be, impacted by the disease. And that involves buy-in and the expertise and the experience of the doctors, the nurses, the midwives, the minds that are living in these places to understand how to best implement these particular solutions. So I'm just sort of outlining some of the problems that exist. And the question then becomes, what is the solution? It's a big thing that we at SEED are trying to do. And, it's fairly simple. I don't have the pictorial, but I'll draw a map, I'll draw the table for you. So in 2006, the World Health Organization wrote their entire World Health Report on people and the need for people. And in it, they wrote a table or a graph that I think is critically important. What you have on one axis is survival. So on your y-axis, you have your survival. And on your x-axis, you're going to have number of healthcare workers. And turns out, the more health professionals you have, the higher your survival. This was done in women's health and children's health primarily. But it sounds really intuitive, right? More healthcare workers, the more likely you're going to live. Somehow, though, it took that table for people, that graph, for people to actually go, my God, people matter. It isn't just about building clinics. It isn't just about putting medicine into these countries. It's about actually having people to drive this response, to deal with complications of giving HIV medications, of dealing with cerebral malaria, and this is critically important. Also critically important is increasing access for care. So many, many programs have been excellent about increasing frontline healthcare workers. It is important. We have to increase access, and frontline healthcare workers are very important for dealing with the lack of sort of human resources in these countries, right? They're a great bridge solution to being able to help with certain, with illness and disease and to helping people do well. But what they're fundamentally trying to do is to act as a bridge for the fact that there are just not enough doctors, nurses, and midwives in these countries to be able to care for the population. And more importantly, what's really missing is the ability to continue training. So what SEED Global Health is trying to do is very specifically address the fact that what we need are local doctors and nurses who can not only provide outstanding care, but can continue training. Not just across the health spectrum, so they can train community health workers, they can train skilled birth attendants, they can train midwives, they can train another OBGYN, but they can also train for successive generations. And so Seed Global Health designed the program very much with that in mind. We're born out of actually about a 15-year movement to try to create something like this. So as PEPFAR got started, and the idea was that we can actually put people on HIV treatment and care, there's a realization you would need people to be able to do this. So a lot of reports came out, and actually Senator Frist of Tennessee put a bill on the Senate floor in an attempt to create this global health corps, this idea that you would send Americans abroad to teach, to train, to transfer skills, but it never quite got off the ground. So a couple of us were together about 5 years ago, and we realized that this was ridiculous. There was so much need. People kept flying over and delivering care, just leaving. MSF, an extraordinary organization, but they deliver care to humanitarian crisis. They're not teaching, they're not training. So as wide of a reach as they had, again, there wasn't this legacy of investing in strengthening health systems. So we realized that there had to be some effort to try to do this. And so we quite literally, we thought about it, and we realized that maybe it made sense to us to have the US government try to do something like this. They were already investing in health, but they weren't necessarily investing directly in care, and there's no program like this in the world as far as we could see, and wouldn't it be great if the US government could lead on this? So we went to a forum with the Peace Corps, and the then Peace Corps director was speaking. We actually just asked an anonymous question at the end of this forum. We raised our hand and we said, what do you think about the Peace Corps sending doctors and nurses abroad to be healthcare educators, to teach, to train, to build capacity, provide technical expertise, not just care for people and save lives? And we were delighted when the then director said, yes, that sounds like a great idea. I actually don't think he thought we'd come down and sort of say, great, we're going to come to Washington and let's make this happen. But to Aaron Williams' credit, he invited us to DC, and so was born this conversation to begin to have this program take shape. It actually was sort of lovely, because when President Kennedy gave the speech at the University of Michigan, when he was then a candidate, he gave the speech at about 2 a.m, impromptu, on the steps of the University of Michigan, and he just asked the question. He pitched the idea of the Peace Corps. Unbeknownst to his advisors, he just put the idea of the Peace Corps out there, and he asked very specifically, who of you who are going to be doctors will spend your days in Ghana? But the Peace Corps had never actually created that kind of program with technical capacity of doctors and nurses going out. And so they were coming back to this vision full circle at the time that we sort of approached them. At the same time, PEPFAR, the President's Emergency Plan for AIDS Relief, which had sunk $15 billion into HIV care, had then reauthorized another $48 billion to try to go to HIV care, realized they couldn't do their work successfully unless they had healthcare workers, trained, skilled health professionals to lead the effort. So they actually had a plan to train 140,000 healthcare providers, and they had no idea how they were going to do it when we rolled along, which was very, very good timing. And so PEPFAR funded us to work with Peace Corps to send doctors and nurses abroad to be educators, to teach and train. We launched our program in 2013 with 30 doctors, nurses, and midwives, traveling to Tanzania, Malawi, and Uganda, and working with 11 sites in those countries. We are actually going to be sending our 4th class this year, and we're going to be doubling the size of our program, which I will get to shortly. But it was a really exciting time, because over the last 3 years, we have trained close to 10,000 doctors, nurses, and midwives in our 3 countries, just 105 volunteers. We have done about 104,000 service hours and taught 344 new classes, competencies, skills, and teaching modalities. The impact has been huge. The countries where we're working have asked us to go deeper and broader and to bring more volunteers. We have a waiting list of countries that have asked us to come, which has been, wonderful and exciting. And we're going to be launching, actually, this July, we're going to be going to Swaziland and to Tanzania. So Swaziland has the highest HIV rate in the world. And Liberia. It's where the exhaustion's kicking in. And Liberia, we're going to help rebuild after Ebola. So we actually got a personal invitation from the president of the country. She asked us to come and to try to help train the needed health professionals in our country, because she realized her country would never be able to cope with Ebola in the future, or the epidemic, unless it had the skilled health professionals it could have. And it's exactly what Ebola showed. It spread like wildfire in those 3 countries in West Africa because the health system was so fundamentally shattered. There were not enough skilled health professionals to be able to raise the alarm, to mount a response, and to be able to help advocate for the kind of support and care that was needed in the country emergently. And so recognizing that, Liberia's now put out a huge 10-year program to train up all of its skilled health professionals and healthcare workforce across the board, actually. And it's asked SEED to come in and help lead on the health professional piece of this. So we're going to be training doctors, nurses, midwives, and nurse anesthetists now over the next years to help them scale up this particular part of the healthcare system. And I think it's very interesting because we are increasingly realizing, I think, in the world, it's a small world now. Airplane travel, technology is all bringing these problems directly into our own doorstep. I didn't mean to make light of Ebola and what happened, but in Dallas, it was just appalling to me how much this country freaked out about Ebola here. And it was really fascinating to me, too, because you have this one gentleman that got extraordinarily sick. He was staying in an apartment with his fiancée, and I believe she had 5 children. Not one of them tested positive for the disease, despite living in this incredibly small setting. So, as much as we worry about these diseases coming here, fundamentally, we're able to cope with them when they do come. 2 nurses got sick, but look at the treatment and care that they got right away when they got sick. They got treated immediately. They got the needed, therapies. They basically spent a week in a hospital bored, scared but bored, and they did fine. And I think that should be the realization of what a huge gap we are dealing with. Thousands died in these 3 countries around the world, but they actually didn't need to. We always said that Ebola was a mortality rate of 90%. My guess, it's probably closer to 10, less than influenza or the flu, if you can actually provide the treatment and care. And we're starting to see that through the data that we know. We treated about 12 people with very severe Ebola in this country that we brought back. We expatriated from West Africa. All of them survived. So what we're fundamentally dealing with are 2 standards of care in the world. That's what we're trying to change. But we actually have the ability to change if we are willing to dive in and do the hard work that is needed and make the investments that are needed and be thoughtful and strategic and be long-term in our vision. One of the tricks that we have, and we partner with the US government, and we're incredibly proud of this partnership, but you have to report annually on your results. You have to get appropriated on an annual basis or within 3 years, and it's very difficult to do long-term planning. But if we're truly going to solve the hard problems of the world and see a difference and close these gaps, we need to start thinking in more complicated terms for longer term and be willing to make those kinds of investments and commitments. Because then I think in 20 years, we're no longer going to say, well, we just spent billions in this disease and we've made progress, but we're still not as far as we need to be. I think we can say Liberia has all of the healthcare professionals that it needs, all of the healthcare workforce it needs, and we can just be there in a mentorship and support aspect now, not actually having to constantly be in and providing care. We might be able to say that about Tanzania, or we might be able to say that Swaziland no longer has the highest HIV rate in the world. 1/3 of its population has HIV. We're in 2016. That should not be the case anymore. We do know that we're beginning to make a bit of a dent in this. I think that we're young as an organization, but we're trying to be very thoughtful about our monitoring and evaluation a bit to understand the impact of what we're doing. And so we think of it in terms of, right now, outputs. We've certainly got a sense of our outputs, how many healthcare workers we've trained, how many classes we've taught, how many sites we're at, what the impact's been. But we want to think beyond that. We want to be thinking about behavior change. We want to be thinking about reversing that brain drain. We want to think about what is the leveraging model. If I've trained, Dr. Tobias in pathology, I want to know that Dr. Tobias is training people, himself in southwestern Uganda, and that we're seeing that impact last over generations. So we think about value added to education and training. We think about sort of paradigm shifting and empowerment and leadership through that, and we think about engaging in scholarship. Reasons that we've tried to focus on some of those areas as we've gone forward is that we know that reasons that people leave their country are because they can't practice what they train. It's not just that they're not getting salaries that they might see in other countries. It's also very much that they want to be able to feel results, to know that they've actually had an impact. Esther Johnston, who is one of our staff now, but she was a volunteer in our second year, she's a family medicine doctor, and she worked at a site in Tanzania. When she first walked on the wards, she literally walked in the wards and she saw dead babies lying in the ward. It's a shock. You work in a system here, you know that you can try to do things, and you lose babies and you lose people here, and it's hard. But it's really shocking to just kind of see the numbers that you see in this setting. And so she just quietly watched and observed to figure out a little bit about what was going on and why this was happening. And what she realized is that people couldn't recognize respiratory distress in these babies. They didn't quite identify what was happening. And when they did recognize it, they didn't know how to adequately step in and try to make a difference with it. So she started training. She started helping them recognize this is what distress looks like, and this is what we do about it, and this is the differential diagnosis that you should be thinking about, and here are the steps that you can take to actually reverse what's going on. So about a month in, she came on the wards, and they would say, oh, Dr. Johnston, this baby was on oxygen overnight, but we suctioned the baby and we stimulated the baby, and they're doing much better. This baby just needed to be warmed by their mother, and we advocated for kangaroo care, which is where the mother holds the baby and uses her own warmth as an incubator effectively to keep the baby warm enough. And it should be off oxygen in 2 hours, and suddenly baby started surviving. Well, the morale of her students and the faculty went up immensely. Then they started organizing trainings, and they held a training for 200 health professionals in the country. And what ended up happening is that there was so much excitement around those health professionals getting trained, and they got very excited. They're now taking her student, one of her Tanzanian students now has been organizing trainings that he's taking around the country to train more people. Tanzanian-led, training more people, morale is going up, and lives are being saved. We have another volunteer who's an OBGYN who worked in northern Tanzania. And so she, within 6 hours of being at her site, got called to the operating theater. And they said, you have to come urgently. She didn't even know anyone's name. She walks into the operating theater, and she sees that there's a woman on the operating table, and she knows it is too late to try to save the mother. But she figures, at the very least, she should try to save the babies. And she can't save them either. Totally shocked by this experience, she writes us. This woman has been literally at her site for 6 hours, and she writes us. This is our first year, too, by the way. So we get this email, and we think, oh, my God, what have we done? And she's sort of shocked, and she talks with us. She says, but tomorrow has to be better, right? And we're all fingers crossed. And she writes us the next day, and it just says better with a question mark. And we're thinking, oh my gosh, what's happened now? And it happened again. She got called to the operating theater, and again, there was a woman in complete extremes on the operating table, pregnant. This time it's because she'd been laboring the village for 3 days, and no one had realized to bring her in earlier. So they basically, she's in complete extremes. And so Maureen, our OBGYN volunteer, performs the life-saving procedure and saves this woman's life. This is a mother of 5 children who will now go home to those 5 children. And the data tells us that if you're 2 or under and your mother dies, you're more likely to die. And it further tells you that if you lose your mother at any phase in childhood, you're more likely to be socially and economically disadvantaged through your lifetime. So 5 children's lives have now been positively impacted. But more importantly, her counterparts then had spent the year with Maureen learning when to do this surgery, how to do the surgery, and how to save more lives. Ruptured uterus happens all the time in these countries. A woman dies every hour from a complication of pregnancy or childbirth in Tanzania. So Maureen single-handedly transformed care in her part of the country. She did it also by teaching nurses. So she taught 45 labor and delivery nurses at her site the latest protocols for labor and delivery. And about a week later, some doctors came to her site, some clinical officers came to her site for a conference, and they said, hey, when did you come to the district and teach all of our nurses? And Maureen said, I didn't. What are you talking about? The 45 labor and delivery nurses she had taught then went out into the district and ended up teaching others. So there's a horizontal impact to Maureen's work. Third story, the creativity and the energy of our volunteers. So Maureen discovered that nobody knew how to deal with vaginal lacerations. This is a great lunchtime topic, right? And so Maureen realized this, and she didn't know what to do because this is really important. It causes pain. Women can be shunned for the pain and the complications they have from this. They can be incapacitated. Their sexual lives with their husbands can be a problem. They can then get rejected. It can be a real problem. She realized this is something that she really had to deal with. But how are you going to teach all these students and women, you kind of want them to have a little practice, understand what's going on first. So she built models out of coffee foam and filters that she went down to the market and and coffee filters that she went down and she bought at the market. She just built some model vaginas and she taught everybody how to fix them. So suddenly she'd empowered all these students as well. Again, changing impact. So what we've also learned is that we can save lives, but we can keep people in country as well. So we've been told by some of our sites that for the first time ever, they've had graduating students that have asked to stay and work as faculty at their sites rather than try to leave and go back to the capital. That's going to be a big difference if we can keep people in place. We've been paying scholarships for people now to get through the pipeline, and the government is agreeing to hire them into the public sector after they graduate, and the students are agreeing to stay in the public sector and continue teaching. So we're hoping to have an impact as well on that level. And I think finally, just to conclude, to be sensitive to time, we think we're having an impact at home. Because there's going to be a population here in this country is about 350 million now here, but it's going to rise to 440 million by the year 2050. And about 82% of that growth is going to be immigrants and their children. So a lot of these global health problems that we think don't happen in this country are going to be happening in this country in a really real way. And we are going to be impacted by it as a system. And so we know that people who work in resource-limited settings, health professionals who work in resource-limited settings, are more likely to work with underserved populations in this country or to work in underserved specialties. They are better at understanding social determinants of health. They're better clinicians. They're better history takers. We are building alumni now that are going to be coming back to this country and working here. Just here in Chicago, Dr. Bronwyn Ray is an anesthesiologist who went to Dar es Salaam, Tanzania to work. She's now here at Northwestern helping them build out their global health program in order to increase bilateral exchange and to be able to understand some of the impacts of this here at home. So we see this as an investment in our own healthcare system as well. And it's just been an extraordinary privilege to see this program grow, but I got to tell you, our work is just beginning. I mean, we have a wait list of countries that we don't know how to get to, and there are 82 countries around the world with critical shortages of doctors, nurses, and midwives, and we're only in 5. So it's exciting, but we are looking forward to trying to make a dent into closing this big global gap, and I really, really appreciate your time today to have a chance to have a bit of a discussion. Thank you.
Thank you, Dr. Kerry. Now, as is our custom, we're going to turn out to the audience for your questions. So if you have one, please raise your arm. We'll bring a microphone over to you. I'm going to get started, actually, while people... Oh, Jenny will go, then I'll go next. There's one coming to you.
Hi, I was just curious, when you determine that you're going to enter a country, what is the timeline or the first steps that you take within that country? What are the relationships that you feel that you need to have before you can even send a volunteer there?
It's a great question. So it depends a little bit. You're catching us at a point where that's evolving. When we first started in our first 3 countries, it was a huge amount of planning. We went to sub-Saharan Africa because of the global burden of disease and the lack of the healthcare workforce. We went to countries that already had some U.S. investments in health because we were going to be going in with the Peace Corps and we wanted to really leverage it. We went to countries that spoke English because we wanted to have some element of success, although, like everything, there's surprises, right? Turns out in Tanzania, a whole lot of informal education in Swahili, and there's Quechua and Malawi, and Uganda's got 52 dialects, so it's been a bit of an adventure. The beauty of partnering with Peace Corps is they've got very intensive language training, though, so we've tried to take advantage of that. We want to be invited in by countries. So when we first started, we approached the countries, but then it became an invitation, and they sort of guided us to what sites we wanted to go to, and it was a year of planning. It was site visits, it was figuring out, where we could add value, what the needs were, building this sort of dorky online dating system for medicine where the sites tell us what they want and we read CVs and we match and the sites approve and everyone gives a thumbs up like button. So that took a great deal of planning because we were designing the program. I think now as we've expanded in the countries, for example, it's a quick site visit and it's an understanding of do they have the vision, are they going to buy in? Can they provide housing? We want sites and countries to be making a contribution to the program, so they have to be able to provide housing. It's much faster. We've been planning Swaziland for a year, though. Again, prolonged site visits, visiting with the ministries, sort of mapping out what's the ideal mix. We, however, got a letter to go to Liberia last fall. We did a site visit in March. We made the decision a week later, and we're sending volunteers in July. And I think that we're in a position now where we have enough applicants coming into the program. We have 100 qualified doctors, nurses, and midwives that if we had the funding, we could place this year. But we can't because we're not funded. But we drew from that surplus to send them to Liberia. And so that allowed us to mobilize to Liberia incredibly quickly. We've been asked to go to Sierra Leone. We've been asked to go to Ethiopia. We're being asked to go to Kenya. We're asked to go to DRC, South Sudan. There's another West African country that I'm now blanking on. But it's been a real, I think for us, we could mobilize quite quickly at this point now that we have the system and the rhythm. If we move off the continent, I think we'd go a little more gingerly just because the African countries are so diverse that maybe it actually won't matter because one country to another on the African continent is completely different. But language would probably be the biggest barrier, I think, depending on where we go. But our dream is to be having a dent in at least 15 countries at once, working ourselves out of our own job and then moving on. But it just depends on the type of work we're doing. And maybe there's a chance I'll talk a little bit about the consultancy model we're building out, but I want to save time for other questions.
Sure. Okay, we can go right back here, and we'll come up here next.
Hi. I have a question regarding how you deal with the inherent cultural norms in some of the countries. I had worked in Tanzania on a mission trip, and although we did try to teach, it was extremely difficult to get the buy-in from the patients of, yes, this is a symptom of malaria, this is what you have to do. So how have you been successful in getting that buy-in in those different countries?
It's a great question. Cultural norms are incredibly important in this work, and respecting them and understanding them are incredibly important. So we actually our volunteers come together for 2 weeks in July in Washington, and we go through an intensive orientation where we spend the majority of the orientation actually talking about what it means to practice and to teach in a resource-limited setting and across cultures. We call it the voltage change. And we want people, and we tell them for 3 months, your job is to look, listen, observe, don't try to do anything. We send our volunteers for a minimum of a year on purpose because it takes 6 months to know where you're working and to build the trust and to build the partnerships that it takes to actually be effective. And that has made a huge difference, we have found from other programs. We've been told that by our counterparts, our partners. Our volunteers have reported that they hit January and they suddenly go, because they go July at least, and they suddenly go, I am so much more effective. We tell them to go to weddings, to go to funerals, to sit and have tea, to have meals, and they really get integrated in a way that allows them to understand these cultural barriers that keep them from being able to work. On the flip side, though, and actually, one of my favorite stories is that we had a volunteer in southwestern Uganda. He is a white guy from San Francisco, nothing like the Ugandans, and he was under a bed fixing a Foley catheter when a tour came through the hospital. And the visitors turned to the tour guide and basically said, who's the white guy under the bed, or who's a Mzungu, which is the term for a non-Ugandan foreigner, sort of, not one of you under the bed. And the Ugandan host turned and goes, oh, that's not a Mzungu, that's one of us, that's Ari. And that was such a statement to me of how integrated our volunteers have gotten. And it's part of the beauty of working with the Peace Corps, having that kind of programming or mentality. Not all of our work is with Peace Corps. We actually send volunteers separate from Peace Corps, and we do a lot of other programming that's in complement, but we still keep that same mentality of integration. I think it's been really important. But the other thing you have to remember is that in hospitals and sort of Western medicine, there's not a lot of trust of it because it's seen as a failure in a lot of these places because it's been underfunded and these hospitals have fallen apart over the last 30 years and there aren't enough medicines or the medicines are counterfeit. People don't trust the system. Hospitals are where you go to die and this kind of, so people aren't going to buy in because they haven't seen that it works. So some of this is a patience game. If we can start to show that we're going to save lives and people can trust us to come to the hospital, we're going to also be able to make a dent in that as well. But it's time. It's time and trust and partnership. And I think the difficulty with some programs is if you don't have that time to build that trust, it's going to be really hard to get over that hump.
Speaking more to on-the-ground effectiveness earlier, we heard from Andy from Abbott, who talked through what you're doing in Tanzania. Can you talk more about how you're developing public-private partnerships and working with other people who are already on the ground?
Absolutely. Our whole model is based off partnership. I mean, we leverage one with the Peace Corps. We are working with some NGOs and folks that are on the ground. Everything we do is a public-private partnership in the sense, too, that we work with the public sector in the countries where we work. So that's one of the things that distinguishes us, not just that we're doing education and training, but we aren't creating a parallel system. So some groups go in and build a center of excellence, and it's great from a care standpoint, but it's a never-ending well for that organization that has built it in some ways because there's no plan to kind of scale up and create self-sustainability. And so we really only work with the public sector with the idea that we are going to try to build a safety net that can be scaled across the country in its entirety. And so that's critically important. But there are people who are already working on the ground, and so we try to be thoughtful about that and to leverage it and to work with those folks effectively. So one example is the Touch Foundation in northern Tanzania, which has been there for a long time. It's a Cornell and McKinsey-based organization that has been doing healthcare training in northern Tanzania. And we're now partnering with them to do nursing leadership and fellowship so that we're going to fund specialty training using our volunteers to train. They'll train nursing specialists and create nurse leaders because 80% of healthcare actually is delivered by nurses, not necessarily by physicians. And so changing the paradigm around nursing and empowering nurses to be able to be advocates, but importantly for others to see them as that and respect them as that, and to allow nurses to actually deliver the care that they're trained to do, can be really powerful. And so we're going to be doing a lot of work around that, but it is a partnership with the Touch Foundation as much as it is with the government of Tanzania, because that's how we're going to be able to scale it out. That's just one example. We do get some funding from the U.S. government to support our core work, but we don't get nearly enough. Our budget next year should be $6.3 million, and we only get 1.5 of that as federal funds from the U.S. government. And the rest of that we're trying to raise. So we rely on being thoughtful, like partnerships with Abbott, where we work with Abbott to help meet common goals. Abbott's done an incredible amount of work on creating training and expertise at the Muhimbili University of Health and Allied Sciences in Tanzania. And so we're trying to complement that and help expand some of the specialties and then also integrate with some of the work that Abbott has been doing in the ER. And so the need is infinite, right? So we can be very thoughtful about how to fill some of that need by leveraging some of the work that's already ongoing while trying to be creative about how to expand it and make it go a little bit further.
You're accomplishing a lot for a $6.3 million budget. Congrats. Alicia, next.
I wanted to ask a funding question, actually, to follow up on that. So there's been a lot of initiatives to sort of address disease-specific issues, right? You talked about PEPFAR. There's the Global Fund for HIV, AIDS, and TB. Malaria, I'm missing one there. There's Gavi, looking at vaccines. It seemed like Ebola kind of woke people up a little bit to the weak health systems piece. Have you seen a movement towards a global fund for health capacity or something of that kind?
I wish. I'll start it. So one more thing to do. It's interesting, right? There has been a lot of disease-focused initiatives. A lot with the Millennium Development Goals did a really good job of actually helping to spur that because a lot of their targets were very disease-focused. And interestingly, if you look at the Sustainable Development Goals now, there's 17 goals and 169 targets, I think, but all that says to me is that they needed to be more comprehensive because at the end of the day, we are living in one big interconnected matrix. And so you can't do anything in isolation. And I think to that effect, that's been the big push for systems. Ebola did wake people up to systems. Now, what has happened is that there's been a lot of attention on fixing the systems in those 3 countries. There has not been a global realization that we need to fix the system in every country. And I think that that's been hard for us. I mean, my colleague Mark is here, and Mark has been tremendous because he's my partner in sort of building our partnerships and our development. And I have to say, one of our biggest frustrations is that what we do is going to take time. It's messy. It is much harder to say, I gave $100,000 and I vaccinated 200 children is a beautiful thing. It's much harder to say I gave $100,000 and I'm a big part of a 10-year plan to see all the healthcare professionals in Liberia be trained. It just doesn't sell as well for people. And yet, it is probably the most fundamental investment that you could make if we're really going to change the world and change our outcomes and change it better. We have poured billions of dollars into global health. We have a lot to say for it, but does anybody here feel like don't need to still be pouring billions of dollars more? That's what we're trying to change. I want us to be here in 20 years and say, you know what, we've trained enough people in Liberia. We don't need to pour that money in there anymore. And it doesn't say they're not going to still need work and help, but it's going to be less. And wouldn't it be amazing if suddenly there's a Liberian person who can write a grant or stand here at this podium instead of me and tell you what the agenda needs to be? And so that's the goal that we're trying to. It's not there. Everyone says, have you talked to the Gates Foundation? Oh, I have talked to the Gates Foundation. I have talked to them 5 times, and they're no interest. It's like eyes glaze over. And so it's really tricky. And I think for us, we welcome people to take this journey with us because we think it is really the fundamental game change, but it is going to be a little bit messier. But look, the big problems of the world are messy, right? Look at the Middle East. Not to get totally political for a moment, but that's one of the most complicated situations in the world. The solution, therefore, is not going to be simple either. It's going to be the same thing in health.
All right, we have time for maybe 2 more. We can go here, and then we'll come over to this table next.
Hi, thank you so much. I was wondering if you could talk a little bit about the mental health component alongside the primary health component. I worked in Malawi with the mother-to-child transmission of HIV and in Turkey with the Syrian refugee crisis. And I found that with organizations, a big push is on primary health care, but also the importance of mental health alongside of that is increasingly becoming more on the global health sphere. And I just wanted to know if you can speak a little bit to that in your experience.
No, absolutely. Mental health is critically important. 1/3 of the global morbidity, so not deaths, but just suffering and disability, is from mental health or related to mental health. And it is a completely underrepresented area for discussion, but not just in global health. I mean, in this country, the stigma towards mental health is shocking. I'm actually a child of an advocate of mental health. My mother wrote a book on depression because she felt like nobody was ever talking about it. So this is very sort of near and dear to my heart. And in global health, it's really important too because it is so fundamental. I mean, think about postpartum depression, underdiagnosed in all these women, and that is so. It's a critically important area. Most countries don't have a psychiatrist, or they maybe have one psychiatrist. The way mental health is dealt with is that people are chained to walls, kept in cages, and it's a really complicated area and field. And so what my hope is, and this goes to the systems and the integration, right, is that if you're doing primary care, build mental health in. You can do screenings around depression or for bipolar or for epilepsy, which is often mistaken as a psychiatric disorder rather than a sort of a medical disorder. We are trying to build that into a lot of the work that we're doing. We're going to be sending a psychiatrist next year. We had a psychiatrist in our first year. We've had mental health nurses that have been doing work, and we've had a couple who still go back and do continued trainings in mental health. But one of the things we're trying to explore is there a way for no matter what specialty we send to be thinking about how to incorporate mental health into the work that they do. And I think that there are some programs out there that are thinking about how to do just that. How to take basic tools and skills in mental health and then build it through other NGOs and other programs in order to have a broader reach and sort of get something out there. So it's an incredibly important area. It has been wonderful to see that conversation. In fact, the World Bank's spring meeting was just on mental health, which I think is very exciting because when you get that level of discussion, hopefully something can begin to happen. And it's a critically important area, so I'm glad you raised it.
I saw maybe 2 hands at this table. Let's go here for sure. And if we're quick, we can get in 2.
All right, I'll be quick. It's my fault. Question and speech, not
Right.
Q&A.
I commend you on your great work in this building capacity in these countries and having generation after generation of health providers. But these health providers are dealing patient by patient. Along the way, are you able to train them in public health advocacy so that prevention policy, that these people can be leaders in their community to prevent the NCDs, tobacco control, alcohol control, unhealthy eating? If we can do good public health policy and have these people as spokespersons we might not have to treat our way out of the next generation of problems.
God, I wish we were all better at prevention. You're absolutely right. I mean, the billions that would be saved through prevention, the lives that would be saved, is tremendous. It is very much integrated into what we do. We don't necessarily, our core mission isn't necessarily doing the public health advocacy, and there's a lot of work in public health that we do try to integrate with and build on. And this has really been, I think, the areas where other programs have excelled. CDC and Peace Corps actually, 70% of its programming is in health or education through its generalists, and so there's a huge amount of public health advocacy. And interestingly enough, Peace Corps' program for malaria prevention has actually been adopted by Senegal countrywide, and they're now using it all across West Africa. So we are trying to really integrate with some of those programs. It's not necessarily our lead, but it is a ripe opportunity, and I think you're absolutely right that that's where we always, everybody, every single person in this room needs to be framing, is changing the conversation towards that.
Did you still have a question? Yep, right up here. Same table. Yep.
Hi, thank you. My question was, what are some challenges that might impede these healthcare professionals who have been trained to keep going and to training others? So for example, whether it be just difficulties in trying to procure equipment or perhaps gaps in healthcare, hospital, clinic administration. Can you speak on those challenges and how to best address them?
I definitely can. I don't know if I can speak to how to best address them, but the challenges are really real. I got asked earlier today, what is our biggest challenge? Our biggest challenge is that we don't control all the levers that impact people and where they go and how they stay. And every human being, I think, should have the fundamental right to move, to make the decisions they need to care for their family. So data would tell us that people leave their country or leave the public health system for multiple reasons. The top two competing reasons, and it alternates depending on what country you're in, of why people leave is salary or professional development opportunities. Salary, we can try to influence. We're only going to be able to do that with the conversation with the governments where we're working, and we're trying very hard to begin to engage in that conversation and to convince countries to allocate more money towards health and to put it towards people and to think about salaries. In some cases, that's just a dead end. Malawi, no budget. Its entire health budget is basically donor funded. There are restrictions on that to some degree, and the money has to go very far, and it's very difficult for them to allocate money. But and these are the trade-offs and decisions we need to make. The Global Fund for AIDS, TB, and Malaria is trying to step in and help with that. And I think to the degree that we can advocate as people working on the ground and say, look, here's the real issue, right? We're training people. We're producing a pipeline, but why should we be doing this work or producing a pipeline unless you're going to hire them? I think we actually have a huge amount of leveraging power in that, because people do know that have told us that what we're fundamentally doing is the right thing. So then we can say, fine, if we're going to make this time and investment, you need to, we can say this to the country where we're working. We can also say it to, I think, international partners and try to have that. But the other big reason is professional development opportunities, and that we can have an impact on, and that we are having an impact on. So if people can practice what they train in, have the tools that they need to be able to actually they are much more incentivized to stay in the system. If you can create opportunities to be part of an international discourse or to go to conferences or to be a part of something bigger, you draw a lot of strength and I think a lot of energy from that. And those are opportunities we're trying to create. Equipment is really real. We do what we can to leverage partnerships to get equipment. So here's an example with Abbott yet again. Abbott gave us a donation, not the foundation, but we got because of the foundation, we were able to be able to figure out who at the actual business we could talk to get something called an iStat. It's a handheld device that lets you run labs in real time at the bedside. So suddenly you can give patients treatment that you need to monitor their labs for. Our volunteers are going nuts because they are suddenly able to save lives and make a difference, and their counterparts are too. It's a really powerful tool. We help leverage that. We brought handheld ultrasound in from GE in order to allow people to do bedside diagnostics, management, and teaching of patients. So equipment is a real challenge as well, but equipment's fixable. There's plenty of equipment. We can leverage donations. People can make a one-time donation to the equipment. Now, you need to do it responsibly. You need a service plan when it breaks and things, but that's easy to fix, right? So I think that some of those challenges are very fixable. Some of them are a little bit more difficult. We do need good schools for people to send their children to. You do need a housing. Housing's a real issue, but again, fixable. We can build houses. It's a one-time, single-cost investment. I think the bigger thing is making sure that there's really a global commitment to allowing these people to, to be paid well and to not live in a conflict-ridden country like South Sudan or somewhere. And those are the bigger challenges. But again, we have to tackle them. We just fundamentally, if we don't take on the complexities of this problem, we're never going to solve it, and we're going to be in the same place in 20 years. I really do believe we can be in a different place, and I really do believe these problems are solvable. I just think it's going to take leveraging partnerships. I think it's going to take truly demanding something different. But if every single person in this room decides to be an advocate and change that conversation, it will change. But it's going to take that kind of, I think, just perseverance to see it through. But I am a complete optimist, and more than that, I just fundamentally believe that it can happen.
Great. Well, that's all the time we have. Thank you again to Andy Wilson and your other folks. And Dr. Kerry, thank you so much for coming today.
Thank you for your time. Thank you so much.